I have to say, I'm impressed that I think all five of you are to some degree sanguine about the prospects for doing subgroup analysis. I hope I'm not oversimplifying what you said, but I pointed out because I thought that you were going to be more dour in your estimates. So it's just an interesting comment. So we've got people lining up. Let's go. We have until 4:15, so we've got a good chunk of time to talk.
This is to both disagree and agree with David. David, the idea of creating risk models or using things that identify people at high risk to create subgroups or create models that say that this person benefits or not seems to me to be useful for looking at those people who may have different absolute risk reductions, absolute benefits. But it doesn't seem like it is the right thing to do to apply to look at the things that might be true effect modifiers. If we've got a treatment that has biological effects, finding those people who simply are at higher risk may not tell us anything about the interactions with biology. I think Mark gave a good example from cancer. If I were trying to identify effect modifiers of the treatment, I would probably start by thinking about the biology, like the biology of cancer, and do my subgroup or those kinds of analyses, not based on a risk model, but based on the biology of the drug that we're working with. And so, I mean, I see this a lot in my field now where people are adopting just that. They're creating risk models, and then they're looking for the effects on the relative risk, which really doesn't make very much sense. And it would be a whole lot more sensible, as a couple of people have done in our field, to think hard about how the biology works, and then create subgroups and risk and models that are not risk models, but models about how the biology might be modified by those factors. Great for absolute risk reduction, but I don't think that it's a very functional way of approaching things that have biological effects and that are strong across all people. And I have one other comment. Right.
So, right, why don't you hold that?
Yeah, I guess I'd like to respond. I don't know if I very much disagree with that. I think a lot of the subgroup analyses that we do actually don't look for biological response differences, males versus females, old versus young, those with diabetes versus those without diabetes. I'm not sure that causal treatment effect modifications is really what we're after when we're doing subgroup analyses of clinical trials, because, I mean, one of the reasons we're so interested in measuring causal effects of treatments is because those are things we actually make decisions on, and we decide to give or not give to our patients, but our patients come to us with a certain set of characteristics, and we don't assign them to them. So what we really want to know is we're just looking for markers of who benefits in terms of in a clinical sense, and often I think the clinically most relevant measure of benefit it tends to be absolute risk reduction, number needed to treat. Now, in terms of looking at relative risk reduction, sometimes I think you will see that there's no reason to really anticipate that when you have groups that vary greatly in terms of their risk of the outcome of interest, why do you anticipate that relative risk reduction will necessarily stay the same? I don't know if there's any good empirical evidence that that should be the case. And especially for treatments that have some treatment-related harm, that's correlated with different variables than the benefit is, you will often see some differences in relative treatment effects because the harm can nullify the benefit in the low-risk patients. So I think I see you nodding. You understand
exactly
everything
right.
I said.
I'd like to see these forest plots put not in terms of relative risk reductions, but absolute
Absolutely.
risk reductions.
I totally agree with
that.
that.
Makes a whole lot more sense to me. But we still do those blobgrams in terms of relative risk reductions.
Yeah.
That doesn't
Agree
make
with
as much
that.
sense. And the other thing is just a comment that in my world, real-world effectiveness and the difference between trials and real-world is creating harm. I think I can give you an example of it because I'd go to conventions with gynecologists who take the view that the Women's Health Initiative results, for example, over the age of 60, don't really apply to their patients. The fact that it was negative or harmful just simply means that it was done in a clinical trial population and not in the real world that I work in. Similar things happen with vertebroplasty, for which there is good negative trial data now that it doesn't work. But orthopedic surgeons are using it worldwide because the trials were done in a trial population, not in the real world. And so therefore, all the trial data that are accumulating do not apply to me. And somehow somebody has got to clarify that there got to be some rules or some sort of judgment about what you mean when you're talking about giving yourself permission to do things in the real world, contrary to the results of trials. And I mean, that's where I'm seeing most of the stuff about real world, and it's real world allows me to sort of ignore the evidence.
Fair enough. Panel, any comments on that? Sandy.
Sandy Schwartz and Penn. Just thinking about a story about a guy who lands in the middle of a hot air balloon in the middle of an empty field, and a woman's walking by, and he says, "Excuse me, ma'am, can you tell me where I am?" And she says, "Yes, you're standing in the gondola of a hot air balloon in the middle of an empty field." And he said, "Well, you must study observational studies and randomized trials." And he said, "Yes, how do you know?" And she said, "The information you gave me is precise and accurate, but of totally no value to me." And then he goes on and says, "You must be from the government." And she says, "Why?" He says, "Because you don't know where you are, you don't know where you're going, and you're blaming someone else." But what I want to change this just a little bit. This has been a terrific day, and I want to thank you and Ralph and the rest of the committee and Mike and the staff for putting together a really terrific day. But every journal editor tells you that when they look at an article, they ask like 4 questions. Is it new? Is it true? How does it affect policy and practice? And so what? And we've talked a lot today about is it new and is it true, but very little about how does it affect policy and practice and the so what. And we're talking about observational studies in a learning health system, and we've talked all day a lot of really interesting and important questions about observational studies, but almost nothing having to do with the learning health system. And I think it's an important question that comes up with regard to heterogeneity in particular, but a lot of the things we talked about, because one thing is to find the validity of the information and identify where the validity may not be true, either due to heterogeneity or other factors. And but to apply it to clinical practice, it leads to you have to make decisions. And so I think a lot of things we talked about today, we haven't been as precise in terms of the questions and the implications for the questions. So, for example, in the last session, we were talking about efficacy versus effectiveness. And I agree with Bob Temple. I can't think of too many situations where something's been shown to work in a clinical trial and does not work when used correctly in practice. But used correctly is important. And when we do a study, a pragmatic trial or a practical trial, and we find it doesn't work in practice, the conclusion isn't that it doesn't work. The conclusion is, what is it about our implementation and our delivery system that we have to change to get it to work? Is it the way we administer it? Is it the way we train people? Is it the way people behave? Mary talked, and I'm picking up a little bit on what Mary said and expanding on it, I think. Mary talked about, looking at it from the patient's perspective. And I wonder today how much when we're talking about heterogeneity, where the heterogeneity of the data becomes swamped by the heterogeneity of other aspects of either delivery or patient preferences. Earlier today, we spent a fair amount of time talking about whether there was a significant difference between a relative risk of 1.2 versus 1.6. Well, it depends what the absolute risk is to the patient. Most of my patients don't care about relative risk. But if there's a large absolute risk, that's an important difference. If it's a small absolute risk, it's not at all a difference. So what, and it gets to, a different mindset. So what I'd like to get a sense of is how do you take the heterogeneity that we're measuring in terms of the effectiveness of an intervention, and how do we study that with regard to what are inherently very complex multi-attribute decisions, which not only there isn't a point estimate. If you look at the slide somebody showed earlier today of preferences, or referred to preferences about prostate disease, even if you understood the data, you're going to have huge heterogeneity in how people value those outcomes, and that's going to swamp that. So, where does this fit in? Where does value of information fit in to figure out how much precision we need and how much error we're allowed to have?
So Sandy, what would you have us do with the remaining time today and tomorrow to bridge the gap between what we're talking about now and what you
I
what
would
you'd
do
like to
exactly
have?
what you're doing and have Joe sponsor another follow-up meeting. Joe's the bank, right? No, seriously, I think we should think about this. The way I think about it is what's missing. You know, it's always harder to see the missing rib than the broken rib, and on an X-ray. That's how old I am. I go back to plain films and not CT and MRIs and ultrasound. But I think the question is, you know, I think I'd like us to think a little bit as we talk about this. Is there anything special we have to do in a learning health system to make it work instead of just looking at this as an epidemiological statistical problem, which is how most of us spend most of our time? So,
Fair
does that
enough.
help, Rich?
Good, thank you. Please.
Can I just make a comment about, you know, I think in some ways if you really believe there's substantial heterogeneity, it's a little bit subversive because, you know, one of the things that we've embraced, at least in cardiology in my era, is like, okay, this trial shows that this drug works, that drug works, that drug works. Corollary, everybody needs to be on every drug no matter what. And it's like, well, wait a minute, you know, is that really, if you believe there's heterogeneity and maybe not everybody is responding to all those drugs, and maybe there's, I mean, you know, does it undermine the idea if we believe the heterogeneity rather than the light bulb model of Mary, that everybody needs exactly the same thing? We really need to think about how that affects our delivery system and what we tell people.
And it gets to the point, I think, where if we make things too complex, we may undermine the effectiveness of things that work.
Well, that's
You know,
exactly. You know,
everybody here
it's a
who
lot
sees
simpler to
patients,
say
the first
everybody
thing we
take
do
this
is try to
pill.
take people off pills.
But just to follow up, I mean, we don't see in clinical practice everybody gets the same treatment, right? I mean, there is this individualization that happens all the time. So there is some learning that's going on implicitly all the time. And the question is, you know, we can generate evidence, externally and give them, but also kind of see how they are learning, how the clinical practice is learning, and
So
what the outcomes
how does
are.
that affect the measurement of heterogeneity? I mean, you know, given that, you know, even as you were saying, you're trying to match the CHOP study, the Philadelphia study, trying to match on all these things, and those of us who do that, we either, like you said, throw out a lot of patients, you know, and we have a precise estimate for something that we know gives us information, but it's limited. But how do you balance the you know, we're trying to, I guess what I'm trying to say, we're trying to narrow down the heterogeneity to make as pure and clean as possible from a statistical perspective. But then we're doing it within a setting where there's huge heterogeneity across patients, across providers, across systems, across socio-demographics, all of which affect the care the patient gets and what ultimately happens to the patient.
Absolutely, and I think some of it was included in the choice model. That some of it we observe, some of the factors, and some of them we do not. And heterogeneity can exist both on observed factors and unobserved factors, and some of these methods can identify that heterogeneity, but kind of, you know, promote future work, saying that there is a value of information is learning more about what drives this heterogeneity, because my current data set wouldn't tell me what's driving this heterogeneity.
Just one comment. Part of it is I think we have to try more systematically to capture the patient experience in short stories, very short stories, because I think that those stories can be very informative as you go back, as you design your next study, as you go back to other data sets about what really happened. And I just don't think we do that. And unfortunately, I think the electronic health record, claims data don't tell stories, and often it's a one-year slice, right? And the electronic medical record as implemented with the copy and pasted note from 5 years ago, you know, also doesn't kind of capture the patient's experience. I think we're going to have to reach to patients for some of that more systematically. Like I said, they're sharing it with each other now. If you look at the message boards and the support groups, and I think we need more of that information to guide what we're doing.
Okay.
Jamie Robbins, Harvard School of Public Health. So, how do you pronounce your name? Anirban? Yeah. So, there haven't been many questions directed at his talk because it was fairly technical, and also he's thinking more like an economist. So, maybe I shouldn't do this, but I'm going to give you, I'm going to show you, I'm going to show you what real heterogeneity is. Okay, so you've got a drug in a population. 50% of people take the drug, 50% don't. Everybody's got some disease, and there's certain survival rates, but the doctors think we should find out which one's good. So they do a randomized trial, randomize, give 50% the drug, 50% not, and they find out that those who got the drug, 52% survived, those didn't, 48% survived, and they said, now we know, everybody in the community, we want you to take the drug. And we know 52% of you are going to survive rather than 48. But luckily, just before they did it, someone looked at how the community was doing before the randomized trial. They had 99.9% survival. It wouldn't be good to treat them with the outcome of a randomized trial. So you see, but now the point is funny. It's all heterogeneity. Yes, 50% of people are hurt by the drug. 50% are helped, and so you won't see any drug effect, essentially, if you give it to everyone. But these people's preferences, that whoever was going to be helped took it, whoever was going to be hurt didn't, and everyone survived. That's serious heterogeneity. So there's terrible confounding, terrible heterogeneity, and the worst thing you could do is look at the results of your randomized trial, just to show you the power of heterogeneity. Now, with that little, think about that. You have to think about that. Oh, and I forgot, the connection with clinical effectiveness is the following. Everybody says we should worry, unlike we used to, about patient preferences. Boy, in this case, should you, because they knew what to prefer. That's why they were all surviving. So my one actual question, I didn't understand, so for complier effects, even when it's continuous, we don't know. You were saying you could tell which effect was. As far as I know, we don't know who are the compliers and who are not at any cut point. So when somebody walks into your office, you've got no data at all to say whether to treat him or not, because you don't know whether he would have been a complier or not.
Right, no, absolutely, that's a good question.
Anirban, use your microphone.
Yes, that's a good question. And the way we establish the individual treatment effect is that it's conditioning on all my observed covariates, which I can observe and kind of act on. But it's taking the expectation of a distribution of unobserved that is more personalized, and not the overall marginal distribution of unobserved covariates, but really the conditional distribution of unobserved covariates, conditional on their choice. Now, that will help us understand better the true distribution of treatment effects, but that would not be actionable, as you said. But what would that give us is that how much unobserved heterogeneity is there, and what's the value of further information to kind of do these other studies, and measure other criteria that could really help us understand those things. So that was the reason. But I agree. That you can only condition on the things that you observe, and you could condition on a multiple things that you observe simultaneously. Yeah.
Steve.
Steve Goodman, Stanford. So one thing, Sandy, about the learning health system. I don't know that we had that title when we started planning. That sort of came later, so it may not be surprising that there isn't a huge learning health system component, even though it may well have been known to the internally. But I'm a little surprised that there's obviously a huge amount of methodologic work in this space, other than what we heard here, and everything we heard here was terrific. But I didn't hear anything about multiplicity, and with the new techniques, and we're going to hear more about this tomorrow with Nick Tatanetti, that alluded to by several folks, including Jamie, the new bioinformatic techniques, massive data dredging, omics, you name it. We're going to find, subgroups, and effectively an infinite number of subgroups that are going to look like they're different. And I'm definitely not a zealot about, correcting for the multiplicity, but it reflects in some ways indirectly our lack of understanding of biologic processes, of explanations. That's what I think it's a surrogate for, our inability to distinguish between one person and another and be able to tell the difference between one sensible subgroup and another. But at the same time, while I'm not very rigid about it, it's something you can't ignore. So I'm wondering how you I didn't hear much about it. I mean, is it just internal validation? What is it, and how are we going to know which statistical results to pay attention to and which not?
Well, let me take as a non-statistician just a simple swing. Is I assume that because this is clearly what's going on in genomics and in looking at phenotype arrays and in epigenetics now, people will take the general approach towards establishing a manageable false positivity rate and validate. And I think there are, I think there's a reasonable pathway for testing and retesting. Now, again, in a situation where there's all kinds of issues about the quality and completeness of the data, and many of the things of greatest interest may not be available for study and evaluation, which is certainly going to happen as we get into the big data era for reasons people have talked about. This all may be easier said than done, but I think the basic outline will probably parallel those kind of so-called unbiased studies, so that if you had, for example, claims data, if you had a 20% sample of Medicare data and you wanted to look at reasonable interactions now, I think that both the computational and methods exist, at least in an unbiased way, to see what the traffic bears. How you'll deal with the information, once again, we're not, I guess I'm a believer that the unobserved things are going to always turn out to be the most interesting, per Jamie's example and per the experience in work that I described before. But among the observed things, I think we should be able to manage. No?
Yeah. Well, I mean, we're certainly doing better in the omics front in terms of the positive predictive value of what are called positive findings today than we were 5 years ago. I don't know how high it is, though, even today. But I'll leave it to others to comment on that.
If I could just make a comment, I think it's a good question, Steve. I mean, for one, David in his, he had some guidance that I thought was very good about this, about distinguishing between the ones you pre-specified beforehand and which ones you're looking at for interest. And I think part of it's N. I mean, the omics things, we have the ability to generate just, orders of magnitude more predictors than we had before, and it gets to be an issue. The second thing is I think it may be the replication side. I mean, if one study is finding something, other studies ought to find it too. And, it's part of that, in any one study, maybe there's a p-value, but if every study is finding the same thing, we tend to believe it. And so that may also be an additional level of control for this whenever people are fishing around and looking for things that might modify the treatment effect.
I mean, what I would add is that, in most cases, marginal technology is only incrementally beneficial for a fraction of the population. It's very rare that it totally is better than for everybody in the population. And so at some point, we have to predict that fraction because at least in the broader sense, in the health policy side, this makes a big difference on market demand and price and all those things if you cannot find those smaller fractions. So at some point, we have to generate these hypotheses. And I mean, there is this problem of multiplicity, and we have to do confirmatory trials. But if we go to a confirmatory trial thinking to do all these subgroups together, we would go nowhere. And so at some point, we have to generate these hypotheses and then, try to decide to do some confirmatory trial, maybe some in an algorithmic way. I mean, that's my view, but,
Mark.
Hi, Mark Berger, Pfizer. Part of a learning healthcare system is also generating the new tools for therapeutics. And it was mentioned earlier today that there's been a lot of late-stage failures, and there's been a lot of concern around the productivity of the biopharmaceutical pipeline. And it's been well known that in psychiatry studies, if you're doing depression studies, you have to do 3 or 4 studies to get the 1 or 2 positive that you believe. And a lot of this is probably due to patient heterogeneity. And we don't really, we're really using very, very standard techniques right now in the industry to examine heterogeneity early in the development process, but maybe the panelists want to talk a little bit about are there opportunities for examining heterogeneity in proof of concept in phase 2, generate hypotheses about that such that you can examine them in phase 3 so we can get much more rapid cycle learning, and we would have more cases where you don't have to go back like ERISA and find out that you can prove that the subgroup worked later on, but actually proactively now will, during the phase 3, be able to prove the hypotheses about subgroups that may indeed benefit more or not have as many side effects from. But are there ways for us to think differently about the standard development process for biopharmaceuticals such that we can embrace heterogeneity and use it to our advantage to get more therapies to the market faster?
Anybody want to respond to that?
Mark, the only way I know that would work is that if you are focusing on kind of seamless adaptive trials, when you start off with many different, subgroups and kind of stop or continue on certain subgroups where you see signals. I mean, there has to be a decision theoretic foundations to do these kind of things in a phase 2 setting. I mean, unless you are enormously exploding your budget to do huge trials in phase 2, which I don't think you are willing to do.
I think we have to begin to look more carefully at adaptive designs so that we don't, once people are in and they've gone through, I mean, the problem with depression, as we all know, is that they're depressed today and not tomorrow and back. So, but within that, I think there's a role for the adaptive design so that we don't, the person has reached a certain point and they're not better, and then we stop. Well, that's probably not what we really need to do. We need to probably re-randomize at that point, so you haven't lost all of the information about it. And then at the conclusion of it, after X period of time, you have more information about what's driving that.
Thanks.
Joe Selby, Corey. Very quick comment on Mark's question. I think you put your finger on yet another interesting conference, which would be one specifically devoted to looking at treatment heterogeneity as a springboard to innovation in drug. I mean, when you find subgroups of people for whom a treatment doesn't work, that's a very interesting subgroup if you can define them and then begin developing something that does work for that subgroup. So, Mark, I wanted to ask about your very interesting findings, which seem to me to identify treatment heterogeneity and to identify it in subgroups that had meaning potentially in terms of decision making. We've heard several people today suggest that as we look for treatment heterogeneity, we should be guided by biology. I have another little comment on that at the end, but guided by biology rather than just mining or kind of looking with crude categories. I didn't hear you say maybe how you came to those categories. I mean, would you say you came to it through biology, or would you say you came to it empirically from what you'd seen in earlier studies? I mean, you got interesting, useful results at the end, and they actually kind of do hold together biologically in retrospectively. But what guided you going in?
I think that's a very good question. There's a number of, these are not really things that I think provide a great biological explanation, or at least not a direct one. It's maybe a couple of layers up. But I think that these are things that you would call core variables in my field. I mean, they're things that like everybody reports that are in everybody's table one. Everybody believes these are important factors. So we're looking under the tree where where everybody has the data on this. I think that it suggests some things that could be done biologically. I mean, one of the questions, is there anything about the mechanism? And one thing that we couldn't possibly answer, and I think would be very interesting, is if you had extremely detailed pictures of somebody's arteries and you're figuring out exactly what's going on in there, can you, would that help you predict who is going to respond better to one versus the other? Are these indirect markers for people who have, if you had a more direct marker, these things would dissolve, of the biology. But I don't think anything we have in cardiology is like, looking at a receptor for cancer and a cancer drug. We expect incredible differences. We expect people who lack this receptor are going to have no response, and people who have it are going to respond spectacularly. We don't have anything that good in cardiology. The other thing to say is that these are fairly crude therapies when you come right down to it in terms of what we're doing to treat the problem. But no, the answer is that these were clinically available, readily available things that everybody has, and the value for them, from my point of view, is that you actually know about them going in. Maybe you could think about it beforehand when you're trying to choose. Whether somebody has diabetes or not, and that may shape how your decisions are made.
Mark?
Yeah, I just wanted to comment that and again, not to play devil's advocate, because I'm sure there is heterogeneity in here, but one concern that one always has in subgroups in thinking about the unobserved things is that one thing that holds together all of the higher risk groups is that they are the kind of factors that I could imagine, unobserved, that a surgeon takes one look at these patients and says, this patient's too old, I don't operate on smokers, diabetics don't do so well, let's send them back to cardiology to do something a little less invasive and keep them off my M&M list, would be an unfortunate source of confounding, but just the kind of endogenous thing you'd worry about in observational data like this.
Just to add one, I do think that it may be that the heterogeneity is a clue. And, it for one needs confirmation maybe in other data sets because it's a smaller effect. But the other is that maybe it points to something that is why is it? We haven't talked about the mechanism. And I'm more of an empirical guy. I'd say, well, I don't know what the mechanism is. All I know is that these people in study after study have done better with this treatment than that treatment. So that's an important thing to know.
Well, just in closing, in addition to biology, I think, and this is back to Sandy's point too about the learning health system, which I agree with Steve. We maybe didn't think through the title quite as well as we should have because we knew it was going to be about methods. That in addition to biology, socioeconomic status, psychosocial status, though particularly in systems and with policy and system interventions, treatment heterogeneity there is rampant and it's very related to things other than biology.
Shelley.
Shelley Greenfield, UC Irvine. I want to ask Mark a question, but I want to pick up on some of the comments that have been made last and say that a lot of these things which we call unobservable are in fact observable if you ask the patients. So polypharmacy, diabetes is a very good example, an easy one actually. Polypharmacy, cost of drugs, multiple conditions, competing comorbidities, competing for quality of life, and even competing for death, as in prostate disease. All these are potentially observable, and we've found that we can actually predict compliance or patient-reported adherence through some of these variables. So what Mark said about what a doctor does, a lot of these things are potentially measurable, especially through the patient. So I think that there's a future in trying to get at some of these variables and measure them and not call them unobserved. And they're not biological. They're other than biological. They're patient variables. But and by the way, there is one drug company that's starting a trial in very elderly people. So it's actually a trial. And trying to do some kind of adaptive design, looking at who is potentially responsive and then shifting management in that. I have some information on that which I can relate, but I don't want to relate it publicly. But Mark, I wanted to ask you use Medicare data, diabetes and so forth. They're not, heart failure is not those aren't diagnoses that are very well defined or measured in Medicare data. Do you think if you had better diagnostic categories, particularly in those two areas, would you have done better or worse in terms of separation differences?
You know, I wish somebody would give me the data so I could figure that out. Okay, well, I'll talk to you afterwards.
We've got both the Medicare data and we've got the data from the registries as well.
Yeah, but you know, I think the point about there's unmeasured confounding, you know, the response is, well, why don't you figure out a way to measure it, is a good one. And, you know, when I hear about big data, I don't think that the thing that we need is more crappy data. I think of the same. I think what we need is different kinds of data that we never had by getting some of these other sources and getting some information about some of these things that may matter to patients. And yes, absolutely, we ought to collect better data. I would just say this is more of a study in principle for today. I mean, in terms of anything else, I think that, you know, treatment heterogeneity, I think, is real, and it has a lot of implications.
The reason I think your data is so real is, even though you're a little skeptical about it, is because there's corroborative data suggesting that those subgroups are quite different in a whole lot of variables which we often call unmeasured. And I'm convinced that you have no trouble convincing me.
Okay, so we have 5 minutes, so these have to be quick questions, quick answers.
Right. Just a couple of points, Mitch Gale. I think the point's been made that the amount of information for detecting an interaction is much less than for a main effect. It's about a quarter the amount of information. So we're starting off with a difficult situation. The biology, I think, is wonderful. One of the few examples that I've seen real convincing interactions have to do with ER and PR and adjuvant treatment with SERMs. So if you know the biology, of course, you're in a very much stronger position. But I'd like to hit briefly on this topic that Steve brought up of multiplicity, and just remind everybody that you know, if you look at 10 groups, you have about a 40% chance of finding at least one significant one. Somebody said, well, maybe we can do better by using models. And I'd like to call your attention to a paper that's in the packets by Carrie Lee et al. It was published in Circulation in 1980. It was a great paper. Basically, he took some data, cardiovascular data, and he randomized the data into two groups, fictitious groups, group A and B, no treatment. Then he started to look at the overall treatment effect. He didn't see much. It was a randomized trial between treatment A and treatment B. But when he started using Cox regression, he found significant prognostic factors. And then when he began dividing the data according to those prognostic factors, sure enough, he found a subgroup, and it sounds pretty plausible to me. Let's see. In the subgroup consisting of 143 people with 3-vessel disease, abnormal left ventricular contraction pattern, and no history of congestive failure, the significance was less than 0.01. It was a chi-square of 10, which he could not adjust away. So you know, so we have the multiplicity problem is real.
So I'm sorry, I'm not familiar with that paper, but in terms of a risk model, I guess with risk, the idea is that you're not doing multiple hypothesis testing, but you're testing a single hypothesis that the treatment varies over different risk groups. And we've done some simulations which haven't been published, and if you're modeling on both of the treatment groups simultaneously, then you shouldn't induce any bias in terms of inducing a treatment effect heterogeneity over those different risk groups.
Right. I think maybe you have a better method. What he did was identify the prognostic factors, build strata based on those factors, and look within those strata to see whether there are different treatment effects. And he found one subgroup where there was a real good treatment effect.
Okay.
These two fictitious treatments.
Okay.
And it was the subgroup we think would respond to a treatment best. Three vessel disease and heart failure. I mean, come on, what could be more obvious?
Okay. 2 minutes, Bob.
Okay.
Well, one minute, and then
just one thought. I think that if one wants to look for advantages and disadvantages of one therapy over another, certain concepts in our enrichment document ought to be considered. If you want to find a difference between treatments, you got to go where the treatment is largest. So just taking an example, if you want to think about antiplatelet drugs, they do their best in preventing recurrent stent thrombosis. They have 50–60% reductions compared to no treatment. So if you want to see where the two drugs differ, you might want to study that instead of something else where the effect size is 10%. The similar example is in depression. It's true, acute depression trials fail at least half the time. But when you take people who have responded nicely to antidepressants and test whether you can prevent recurrence by continued therapy, those trials have never failed to my best knowledge. And the reduction in recurrence is something like 50 or 60%. So if you really wanted to compare two antidepressants, that's the way to do it. You don't want to do it in acute depression. You want to do it in prevention of recurrence. And that's a lesson all over. You want people who have a lot of events, if you can, and you want the subgroup that responds best. And that could affect a lot of our efforts.
Okay, I propose that we let that be the concluding comment of this section. Unless any panelists, do you have any final licks you want to get in? Terrific session. So thanks very much.